So this video will be supplemented with a paper because I have had a lot of trouble with this video and still don't know if it's actually going to upload or work correctly. So I'm going to discuss an interdisciplinary collaboration experience that occurred at Bahia Health, overviewing positive points in the collaboration and highlighting areas that could have used improvement. Reflections of my own personal experience will also be presented. Other points to mention would be implications of poor collaboration, best practice leadership strategies, and best practice strategies that help teams work together effectively. I work in emergency department. As an emergency department RN, we collaborate on a daily basis with other disciplines. We work with our respiratory therapists, radiological technicians, HUCs, ED techs, CNAs, nurse management, and our doctors, just to name a few. One occasion, I had a patient that was being evaluated for chest pain. She was not your typical chest pain patient. She was 30-year-old female, presented sudden onset sharp chest pain radiating into the left arm. Patient has no significant medical history other than she has some anxiety, which was made worse by her presenting condition. Protocol in our hospital for chest pain patients 30 or over, we do initial set of labs, EKG, and then the doc evaluates them and they are followed up with CT. Patient findings showed a negative CT. However, her troponin was slightly elevated, which brought her an admission to our hospital and follow up with inpatient cardiology. The patient ended up staying in our emergency room due to space as a ER hold. Results of her serial troponin showed continuing increases in their level, and her chest pain was not resolved despite the fact that she had nitroglycerin and morphine. Once we take admission of the patient, the ER physician no longer handles the patient. Care is turned over to the attending hospitalist for the patient. I contacted the hospitalist about the patient's results for her increasing troponin. My hospitalist told me, "Oh, that's really interesting." I never got orders for the patient. Knowing the implication of the troponin and how that correlates to the patient outcome, I decided to collaborate with our ER physician, even though our physician was no longer handling the care of the patient. That turned out to be the right decision. The ER physician made immediate consult to our on-call cardiologist and came and physically reevaluated the patient herself. The 30-year-old female patient with no significant medical history, acute chest pain, troponins almost 50 times the normal level, ended up in our cath lab within an hour. And she was found to have occlusions in her heart and had 3 stents placed. Interdisciplinary collaboration with my hospitalist was not successful. The hospitalist failed to reassess my patient or see the significance in the increasing troponins in conjunction with the patient's unresolved chest pain. The patient outcome could have been very negatively affected by that had it been left unaddressed. Other members of the team were collaborated with, and the patient ended up having a positive outcome nonetheless. Myself and the emergency room physician reflected on why going beyond the hospitalist on behalf of the patient was the right decision. In one of the readings that I found by the Association of Critical Care Nurses, they state data from the Joint Commission indicates that breakdowns in team communication are top contributors for sentinel events. My hospitalist, I feel like, had a breakdown in communication regarding the patient, and this could have ended badly for the patient. Ann Watkins, a writer for Mind Body Inc., states, reflection in action, on the other hand, requires a higher level of self-awareness and the ability to reflect on your actions or those of others in the moment the activity is taking place. I feel like that's kind of what I did when I was caring for the patient, when the response of the attending hospitalist was not the right response for a positive outcome. I sought additional collaboration with our ER physician. Watkins further goes on to state that reflection on action is the most common form of reflection. It involves mentally reviewing events that have occurred in the past. The aim is to value your strengths and develop different, more effective ways of acting in the future. Reflection in the days that followed were done both independently and with my ER physician that I was taking care of my patient with. The physician provided me an opportunity to learn from her perspective, and provided further validation on why what I did for the patient, advocating for them, was the right thing. When I spent time thinking about it on my own, reviewing the facts, it's just nurses spend more time with these patients than anyone else. And granted, we do rely on our provider to make major medical decisions for our patient. And we trust their judgment, but we also have to trust our own training and our schooling and our day-to-day knowledge that sometimes they can be wrong too. So at Vihila Health, what happened, they tried to implement a new EHR. It was rolled out quickly by the organization. They brought in an outside agency to help install the system, but didn't give the staff any time really to prepare. The management allowed for zero input regarding the new EHR. The American Critical Care of Nurses cites evidence indicates that nurse involvement in decision making is associated with improved work satisfaction and positive patient outcomes. Failure to incorporate the perspective of experienced nurses in clinical and operational decisions may lead to harmful and costly errors, while also threatening a healthcare organization's viability. Although the organization wasn't left much choice from a corporate standpoint, their teamwork fell apart all the way down through their facility. Staff at the Vila Health reported feeling underprepared and left to fend for themselves during the implementation. Tim Wilkins, one of the authors that I was researching, stated effective interventions offer just-in-time information prior to an experience or task, included effective briefing, provided well-supervised and observed practice with immediate feedback, and followed it with time for reflection and good debriefing. None of that took place at Vihila Health. Staff reported having 4 hours or less of formal training on the new system, and they already had negative thoughts of the system to begin with. Then they were kind of told, go to your IT people, and the trainer that the corporate had bought in didn't listen to staff. He deflected all their questions, concerns, suggestions, and left staff to figure out things on their own. Wilkins went on to state in the reading that I found that sometimes learners do not feel welcomed in the workplace, and this sense of alienation can inhibit their learning. And that's exactly what happened at Vila Health. Because staff at all levels was left fumbling with a new HR that didn't work properly and fit the needs of their facility, their patient care suffered. Multiple staff members reported not being able to tend to patient needs. They got behind in their rounds. They weren't able to chart or had to back chart things. And then some of them were saying they even missed important patient medications altogether. According to the National Institute for Health, identified factors that contribute to successful collaboration were joint venture, corporate endeavor, willing preparation, shared planning and decision making, team approach, contribution of expertise, shared responsibility, non-hierarchical relationships, and power based on knowledge and experience. This was not a joint venture at any level because staff weren't allowed to provide any input. They lacked proper training, and therefore their implementation of the new system was not met with willingness and participation from them. Because the Vila Health IT personnel felt shut down from providing input from the trainer or to the trainer, they also withheld expertise until pushed to do so by superior staff with disciplinary action. Some staff caught on quicker, but because they felt like they had to learn it on their own, they were not going to share their knowledge with anyone else, and said that everyone else had to learn it on their own as well. Demonstrating a clear cause and effect relationship between collaborative team behavior and particular outcomes is often difficult. Published research and case studies report the idea that collaboration leads to improved health outcomes and suggest that collaboration improves intermediary predictors of qualities such as transfer of knowledge, sharing of information, and enhanced decision making. That was from an article by Cashel and Linden called Collaboration and Leadership. When the collaboration suffers, the patient suffers, and then that trickles down to the organization as a whole. Because healthcare is a business, poor patient care reflects on the system. Vila Health employees couldn't appropriately manage their patient care with the new system. It wasn't suited for their establishment. It was meant for large hospitals, and they are small long-term residential facility. Nurses couldn't locate important information. They were missing care tasks. Had that resulted in a sentinel event that would have hit the media, family would have spread the news, and it would have held large implications, both legal and financial, for the facility. The IT personnel at the facility tried to collaborate with the management on the need for a system that was better suited, but their suggestions kind of fell on deaf ears. Nurses requested more user-friendly shortcuts so they could get to tasks quicker, not spend as much time hunting for what they needed to do their job, but their needs also weren't met. Ann Mayo and Anita Woolley, in an article that they wrote called Teamwork in Healthcare, point out team members, especially those in leadership positions or with higher status, should actively invite input to ensure that team members voice all their information. They should also be role models in expressing appreciation for diverse knowledge from all sources to ensure that team members' input, regardless of who the team member is, will be considered and used in the team's work. Leadership in the Vila Health didn't invite or incorporate staff input right from the beginning. Their continuous concerns, struggles for the system were just something that they had to deal with. Staff or management didn't take that seriously. Likewise, the senior staff should have been trained ambassadors, the ones that caught on quicker, had a better grasp on it, should have been on the floor and encouraging other team members, and that was not the case. Many sources agree that successful leadership to improve interdisciplinary collaboration is to abandon traditional idea of leadership as a whole. Joan Wagner wrote that unlike some traditional role models, leadership, such as those that are hierarchical in nature, interprofessional leadership is realized and practiced through a collaborative relationship that is horizontal, relational, and situational. This leadership model is fostered via professional competency and healthy team dynamics. For interdisciplinary collaboration to work, team leaders don't want to rule their team, but instead they want to communicate, share knowledge, foster dependence, and try and create a shared vision. The National Health Institute went on to say competencies of an interdisciplinary team: identify a leader who establishes clear direction and vision for the team while listening and providing support and supervision to the team. The old construct of leadership establishes leaders that would send out instructions and expect their teams to comply and do what they were told. They didn't leave a lot of wiggle room for compromise. Vila Health would have seen more success in their outcomes implementing a process that had management practice more effective interprofessional style. Cashel, that we mentioned earlier, one of my authors, stated that literature supports the idea that collaborative practice is both encouraged and enabled through education and communication-related skills training. Ways in which the facility can train successful leaders include on-the-job training, workshops, role play, interdisciplinary conferences, continuing education that foster the interdisciplinary approach. That probably would have been a good idea for Vila Health, but the management never took that route. So in conclusion, for positive patient outcomes, care of the patient is the best approach from an interdisciplinary model. Providers that participate in patient care must be able to successfully collaborate and share information across the continuum for better of the patient. It's important to facilitate or for facilities to offer training, offer workshops, conferences, Roundtables encourage discussion, real-time rounding, and talking to your staff. Um, that will kind of facilitate the feedback loop. Facilities must also recognize the importance of incorporating that feedback and input from their team and serve as role models when it comes to valuing opinions and perspectives from every team member, regardless of their discipline. The days of the old doctor-patient relationship are long gone. Care teams consist of the family, the nurse, the doctor, and pretty much anybody who is seeing that patient and collaborating on that patient's care. Cashel again states the consensus among healthcare experts from a variety of professions and perspectives is that a collaboratively practicing workforce will be more responsive, efficient, and considerate of patient, family, community roles, as well as providing improved care. Thanks.